Hi, good afternoon, everybody. This is Chris Romeo. I'm the Senior Vice President of the Ventures team here at MedAxiom. We're very excited to have this webinar for everyone, sponsored by Integration Health. We're going to give it just about 30 more seconds to let everybody log in and give everybody an opportunity to get on to the webinar. So give us just 30 seconds and we'll be right back. Okay, so we'll go through just a few welcoming some housekeeping slides. So today's presentation is how to build a sustainable ECMO program in 12 months. We have Ryan Landry. He's the VP of Clinical Operations of Our Lady of the Lake. Dr. John Mehall. He's the President of Integration Health. David Aber, he is the ECMO Program Manager at Our Lady of the Lake, and Nicole Roberts, the VP of Sales for Integration Health. A few housekeeping items, if we can go to the next slide. So if anybody has questions during the presentation, there's a Q&A button at the bottom, and you can pose your questions there. We're going to be holding questions off to the very end of the presentation to let us get through all the slides. But at any time, we'll be reading those, and we can either answer those directly or save those for the end. The second thing to note is that there is a chat button. The chat button, there is a presentation link to today's presentation. In the event that you've got colleagues that couldn't make it, you can download the presentation and share it with them at your convenience. Next slide. So we're going to turn this over to Dr. John Mehall, President of Integration Health. Again, they are sponsoring today's program. And with that, thank you all for joining. Dr. Mehall.
Thanks so much, Chris, and appreciate everybody taking the time to be with us today. We're really going to talk about ECMO, the case for expanding access, why there should be more ECMO done, and how many more patients could benefit from that. Dr. Landry and David Aber are going to speak about their experience at Our Lady of the Lake. And we're going to talk a little bit about the decision to build this organically or partner with somebody like Integration Health to do that. And then we'll get some data on the Our Lady of the Lake experience. Next one, please. So the ECMO opportunity, many people don't understand that ECMO has actually been around since 1971. The first patient was put on, and ironically, it was an adult because a lot of people think of ECMO as a pediatric therapy that moved to adults. And in the last, decade and a half, ECMO has expanded dramatically, and mostly in the adult population. And we see that expansion continuing. And if you think about what's driving this, it's really the expansion of indications. So respiratory failure is growing at about 20% a year, mostly because of aging population and respiratory diseases. And then you have the rapidly growing cardiogenic shock population in the adult world that's driving more and more use of ECMO. And then you have expanded use of ECMO for ECLS, cardiac arrest, PEA arrest, and other things like that. And then combine that with exceptional survival rates. We now see over 70% survival rates for all comers. And if you take out the patients who die during the first 24 hours of ECMO, so maybe for patient selection, you could argue on some of those, but patients who are alive after 24 hours of ECMO have over 90% survival and discharge. So it's really exceptional understanding of how to use the therapy. And there's also a significant financial component of ECMO. It is highly reimbursed and it's lucrative for the hospital. And hospitals obviously like it because it'll never migrate to an outpatient setting. Yet, despite all these factors, the overwhelming majority of hospitals do not offer ECMO therapy. There are fewer than 500 facilities in the United States that offer this therapy. And so there's a tremendous opportunity to expand the footprint of ECMO and really make a major impact on saving lives. Next slide. And so you might ask, why has this not happened? And the main reasons it hasn't happened are some of these myths. So one is that it is a giant financial drain, and we can speak more to this a little bit later. And we also have a webinar coming up May 13th about finances. But when it is coded, charged, and billed appropriately, ECMO should be net profitable to the facility. The other myth is that it's too complex to implement. And you think about you're running blood outside the patient's body through a machine. But we do that all the time. We do it in dialysis. We do it in CVVHD. We do it in veno ultrafiltration and other therapies. And so it's really not that complex, and we can demystify that a little bit. And the last is the poor survival rates, which we just talked about that data. That's really not the case anymore. There were certainly times 20, 30 years ago when we didn't know who to put on or when to put them on or how to manage it, that the survival was very poor. But nowadays, I think that's really just not the case anymore. So I think there's a great opportunity as we can expand awareness and access to ECMO that we could really save a significant number of lives in the United States. Next one. And so I'm going to hand it over to Ryan Landry and David Airbear to speak about their experience at Our Lady of the Lake.
Thank you, Dr. Mehall. Yeah, FMOL Health is a 10 hospital health system across Louisiana and Mississippi. It's sectioned into four different markets, each market having a core medical center. Here at Our Lady of the Lake, we're a not-for-profit healthcare ministry based out of Baton Rouge, Louisiana. We serve the greater capital region. We have more than 7,500 team members and over 600 providers serving our communities. Our medical center has over 800 beds. 100 of those are ICU. We serve as a primary teaching hospital for GME. We have over 60 medical specialties. We're nationally recognized for heart and vascular, trauma, emergency medicine, stroke, and cancer care. Our teams manage around 44,000 inpatient visits a year, and we see over 230,000 ED visits annually. Our CV program is supported by a large integrated team of cardiologists. They provide great subspecialty care for our community. We're also proud of our three-star STS CT surgery program. We have a dedicated thoracic program also with a lot of connectivity to our Cancer Institute. And our critical care team supports six subspecialty ICUs. We're a level one trauma center, our very busy ED department as we sit on the I-10 corridor. We also have a full complement of neuroscience programs and comprehensive stroke status. So I say all that is we are a pretty busy program that has all the things that most of the hospitals around the country would have today. The challenge and years of OMO. So we started talking about ECMO maybe 12 years ago. And really those discussions were generated by our heart surgeons, pretty high volume open heart surgery program. And, there are a number of different reasons over the years why we could not, necessarily move forward. I think if I could go back and kind of glean where we missed having the recent success of our program, it was basically our cohesiveness and comprehensive approach of understanding all the complexities relative to a program kind of limited our ability to get buy-in from administration. And then our most recent attempt was really right before the pandemic, and we kind of lost interest because of the number of different folks that had to, take on different operational needs. The heart surgeons, as they were so passionate about getting a program together, really needed help at the bedside. They're a busy group. The thought of them having a stack of elective cases as well as emergency cases throughout their busy week really didn't give us a whole lot of confidence on the daily management side of it. Louisiana has programs in Shreveport and New Orleans. There really are no programs in the central part of the state. So from a staffing standpoint, we had very little collaboration with established programs and really no accessibility to staff from a sense of like, even picking from a pool of trained staff or migrating folks from a different market. And just like every other medical center, we're busy. We have a lot of productivity focus and trying to maximize all the other services that we're responsible for. And it just never seemed like a great time to get our staff fully bought into the idea of taking on something that was a little bit more dynamic than what they were facing. So I guess our catalyst came in the summer of 2023. We got wind that we were hiring a cardiac trained and intensivist that had ECMO experience and was interested in starting a program. And that was kind of the piece that we had been missing over the years. It was somebody who was going to form in a dyad relationship with myself and champion our developments with all the different community members that we have and all the different councils that we have within the medical center to really advocate for what's needed to build an ECMO program and really build that confidence that that our team members knew that we have. We just didn't have someone that was going to tell us from a provider standpoint that they would be there to allow all the other physicians be able to get back to their normal work. So this table kind of shows what we were facing as far as like building standard programs here at the lake and what the opportunity we have with Integration Health as a partner. We have a really strong process improvement team and quality department, and we are very used to starting programs. We're also very busy. So an administrator like myself, I'm a nurse also, taking the time away from our busy days to go and run a lot of the traps was something that we could have accomplished. It would have taken a whole lot of time for us to do that. Um, the capital expenditure that comes along with it, because of the duration, it would have been sizable. And starting from ground zero and training our staff would have come at an expense. And it also would have created kind of a feeling of we're adding something additional to their already kind of full book. So with integration's help, we had a team that was essentially embedded with our team for a lengthy period of time. They brought talent from all over the country and from all these different programs to help us go through each step of that process. And I'll go into more about that in just a second. But we also developed a performa with our normal case volume and kind of marched that out where we were looking at multiple years before we would be able to cover the cost of the initial startup. Um, and as far as like risk goes, we still had a whole lot of due diligence and getting approvals through either our finance team and our quality department. So. So our implementation timeline in August of 2023 is whenever our critical care physician started, and really through phone conversations before we were able to accomplish a few items and establish some councils. Upon his arrival, we kind of hit the ground running and started looking at protocols. Every ECMO program is a little bit different. So we really wanted to learn about how he saw the clinical pathway and what level of engagement we would have to have with other facilities. And so in December, we were able to sign our contract and know that during that lead up time, integration provided us with tons of resources of other facilities that are out there being active in the ECMO community, pointed us to ELSO and provided us with a whole lot of comfort for our financial team and our coding team. So some of that background work was done before we even had the contract executed in a sense of just discussions about what is needed to move forward. Program build begins in January, and that's whenever the team really lived here with us. There was a project manager that was here that showed up at 7 o'clock every morning. We ate lunch together. While I was able to go and do my normal job, she was networking and meeting all the people within our departments and really hand-holding the process to accomplish milestones. And hiring somebody just to come in and do that would have been impossible as our own employee. So having somebody who was so comfortable navigating a normal hospital structure of our size and know which milestones that have to be hit in a thoughtful progression so that we are doing things in parallel was really important and really shined. And that type of talent was really what got us to that point so quickly. In March, we officially went live. We did a whole bunch of outreach and education internally. And we kind of got to the point at the end of May or the end of April. It's like, are we ever going to put a patient on? And that first patient showed up in May. And we were able to execute all these wonderful things we spent months trying to organize, and it worked out really well for us. So building a program from a foundation perspective, like I mentioned, Integration Health brought us an entire team of experts, someone that knew our EHR, what are the different navigators that need to be built. They provided someone that would help our coding and finance team understand the complexities, taught us clever mechanisms of bill holding, charge review, and implementation along the whole revenue cycle cascade. Um, we were able to get flow sheets built in Epic, and a navigator built in Epic. And I think there's some like canned stuff that's already out there. But we had certain ways that we wanted to see it. Our nurses had really good input, as well as our coordinator, on telling us what we needed, or what they wanted to see and how they wanted to see it. And we were able to get through those. Training, we took over a conference room. We're able to set up multiple days of training, being able to hit physicians, nurses, respiratory therapists, lab teams, physical therapy, occupational therapy, speech therapy, all these different folks over time. Would have been kind of a nightmare for somebody coming back and forth. Of having a team be able to set up training, have it available for everybody for multiple days, and they can come in and out as needed, was really part of that training success. Equipment, like I was mentioning, every program is a little bit different. They really helped us figure out what pumps we wanted, the cannulas. We went back and forth on everything down to the zip ties to what kind of dressings we were going to use, and just having confidence around a group of folks that have such experience as they provided for us really helped our physician and our coordinator. David, do you want to mention anything about whenever you showed up around this time?
Hey, thank you, Ryan. Um, yeah, so having some experience in ECMO field for a little bit, it was really wonderful to see the great job that Integration Health did by building, again, launching the foundation for this program. The collaboration across the campus was just really, it felt very different than I've ever witnessed before. It was just everyone wanted this so badly, I guess, for so long. Excuse me. So walking into this was just made IH and in Ryan's group made this somewhat easy because again a lot of the hard work was done. Epic was relatively built. The education across the team was flowing, and ECMO is one of those things where you can talk about it all day long. It's more you get the non-ECMO person will forget 89% of that, right? So at least the seed was planted for us to kind of push forward with education and ongoing education for all key stakeholders. So I think for me, the biggest plus was just the ambition and the readiness for everyone to move forward with the program.
Yeah, I can give a little bit more on where David came into our program. We had worked with Nicole, and a number of different integration health team members, over a couple months, and especially since we had our contract executed. Our model, we decided that we really wanted to have a coordinator in-house, to provide that extra comfort and extra layer of having an experienced person that was not a physician, with our team. And we were lucky enough to get David. And his presence being around the clock for us really helped us kind of hit the accelerator. His involvement with ELSO, this first year into our program, we were already looking at trying to apply for Silver Path to Excellence with ELSO. We were populating the registry. So there were some other dynamics that fit well with our accreditation heavy CV program, that aligned with having a skilled, experienced coordinator through our contract that made everything feel like normal. Um, so I think that's just important to mention. So the buy-in aspect with our organization, yeah, like I mentioned, we had gone back and forth with this a couple of different times, and didn't really have that physician lead that was going to provide the level of comfort that I think our administration was really looking for. some things that we do really well at Baseline at this organization is have multidisciplinary teams and committee council that allow us to make decisions as a group and leverage the perspectives of a number of different fields. And I'm sure that's the same way in most medical centers. So having this dyad format of, a nurse administrator that's trying to um, fill in the gaps that the physician dyad has while we went from multidisciplinary team, what was important because there were so many different things relative to uh, even blood bank and lab that we were not considering without having those engagements. So we met on a pretty consistent cadence with those teams. We reviewed all of our financials and supply chain problems and opportunities, and it really created this collaborative feel where everybody felt like they were a part of this program. And the funny thing was, like, we had integration staff, and they were literally integrated. They couldn't really tell who was new to the organization or worked for the contracted company, which I thought was, a really um, special thing for us and helped us be able to kind of really get the teams where they needed to be. So yeah, our weekly meetings were multidisciplinary. We had a bunch of involvement from our quality team as well as our med staff, who provided their expertise and kind of drove us into being really comprehensive in our education and outreach to our internal teams. And it became a priority, and it wasn't necessarily built on one person. I think I could have gotten pulled out, within a couple of months of go live, and we had enough momentum and enough interest and enough education to the teams that they could have finished what we had started. So integration provided us with 24/7 coverage. And as a bedside nurse that worked in the CVICU, we are really good at our jobs. Our nursing team up there I would put against any other ICU team in the country. But it was a little they were a little hesitant to kind of understand what it would really take to take care of a patient that's on advanced um, therapies like this. And I think there's a number of cardiac modalities over the years that kind of fit similarly in my mind that, once you kind of get through it, everything feels really comfortable. But we figured out from just some financial planning and overall comfort from a startup that it would be best for our team to focus on the things that they're currently focused on and to bring in specialists that would help to augment. And then over time, as people got comfortable, we can try to find some kind of blended model over time. I think having a coordinator here 24/7 that is providing education and really feeling like one of our team members was a whole nother layer of comfort. Um, and as we've stated, David eventually became our employee, and everybody loves him dearly and still does the same things that he was doing as a contractor. Our staff model is flexible these days. We have some folks that are now trained, and we are still using integration health for the most part. And I don't see that is going to ever change with just the number of programs we have in our area, and the turnover to higher levels of education that is in nursing and in respiratory. All right, from a revenue cycle and billing infrastructure, Nicole, do you want to mention anything on this slide?
I can take this one.
Okay.
Um, so I think one of the things that's really critically important when you're building these programs is to set up the coding, documentation, charging, and billing infrastructure correctly. At Integration Health, we work with literally dozens and dozens, if not over the years, hundreds of hospitals to do financial reviews for them to help them optimize this. And we find that 98% of them are not doing it correctly and are leaving money on the table. And so it's critically important to set this up at the beginning, set it up correctly in both Epic and within your coding and billing systems, and educate your clinicians around what the documentation needs to be, how it needs to be coded, setting the charges correctly, and then billing out that process. And I think one of the things we implemented here was a single person does all this billing. It doesn't just go into a giant pool where a different coder biller picks it up every time. And then each claim is reviewed administratively before that claim is submitted. I think those are some critical steps. We've done other educational events on coding and billing, which you could search and find or ask us and we'll send them to you. But this is a critical step to getting the foundation correct financially.
One thing that I did want to highlight is something that Ryan and David just talked about, and that's the evolution of the partnership in the program. This partnership with Our Lady of the Lake is a wonderful representation of how we can partner together. Yes, we were able to get the program up and started and off the ground and off to a strong start in a short period of time, and we've continued to provide staffing support over the last 2 years. But part of that partnership is for the lake to continue to build out their own self-sustaining program where Integration Health will eventually take a step back. And David has done a phenomenal job from his history as an ECMO coordinator at other programs, working with Integration Health and now over at Our Lady of the Lake. And that's what he has started to build out is training their own internal specialists. Hopefully will always be a part of the program, but eventually will play a minor role. And so I think that's really important to focus on is the evolution of whether it's the Lakes program or any program as we can help support at all different levels of whether you're starting now or you already do 200 ECMOs a year.
I think that's a great point, Nicole. And Ryan actually said it best when he said that, our staff was integrated with their staff. If you've been in the ECMO space for a while, you may have heard of either ECMO Advantage or Innovative ECMO Concepts. And we brought those two businesses together and renamed it as Integration Health for the sole purpose of that's what we want to do. We want to integrate seamlessly into the hospital, and they'll be indistinguishable between our people and your people. And our people may be there periodically, they may be there all the time, they may just show up when you have high census or turnover, but we really want to have that be a seamless, integrated relationship.
And to touch back with both Ryan and Nicole said, as far as doing ECMO, everyone does ECMO a little differently. And I think what's been really beneficial is having the IH team come here. So many specialists come through and talk about their experiences in life. Because all of us in the ECMO field know that we all do something a little differently, but the same result is to get that patient home. And so I have huge kudos to that team members that come here because it was sharing insight from, again, their experience are not just myself and the physicians, but the bedside staff who had never seen ECMO before. So they could hear me maybe bulldogging an idea for ECMO, then you have someone else coming by saying yay or nay, let's try this a different way. So again, that was just really beneficial by having everybody here.
So our results on our program, I mean, as alluded to in the prior discussion, we were really quick to lift off. We had a whole lot of prep work as we worked through prior to our contract with IH and just learning what programs needed. So we were well prepared for whenever the team was really here physically to get us going. And I just can't speak enough to the understanding of how to implement a program and knowing all the hangups that happen, whether it's IS or blood bank or whatnot, and being thoughtful to those things was kind of refreshing for me, having started a number of different programs in a large medical center, and having somebody that could really take that ball and run with it. So that team member is really important. So our volume was more than what we thought we were going to get. It took a whole lot of outreach and a whole lot of communication, which probably needed more of. And we had great survival rates. And we were pretty thoughtful in picking LSO criteria and stuck to our guns. And I think a lot of that has to do with our preparation, our quality of providers, and our coordinator. and the teams that are managing these patients on a daily basis. Um, so we are the first and only ECMO program in our region. And I think that's something that's very meaningful for our community members, and we've tried to do a decent job of getting some of this information out through news outlets and letting folks know that they don't have to leave our area in order to receive this type of care. Not necessarily like they're in a position to make that decision, but it's really educating our hospitals in rural areas to know that they get into an issue, they can call us and we're there to come and help. So it's really touched all the feel good stuff about our mission as a faith-based organization to help those most in need. Um, so
Before joining Integration Health, as Ryan alluded to, I had worked with Ryan in the lake for several years while I was at a device company. We had explored starting an ECMO program for about 12 years at the lake many times, whether it was 12 years ago or right before COVID, and there was always a reason, not to start, or someone was here and then they left. We knew the patient need was there, and not just for the hospital, but also for the community. Again, Baton Rouge being the state of, or the capital of the state, and one of the largest hospitals in the state did not have an ECMO program. So we knew the need was there. Our partnership timing really aligned when I joined Integration Health and the Lake brought on a very experienced ECMO physician champion. Even though with that strong clinical leadership, there were still key gaps that needed to be addressed before launching their program. And that's where our partnership with Integration Health and the Lake really began. You don't have to have everything figured out. You just really need the right partner. Partnering with a company like Integration Health means you don't have to have everything figured out day one. One of the biggest misconceptions we see is that hospitals feel like they need to have it fully built out, the perfect model, before they actually start building the program. The reality is you don't need that. What matters more is having the right partner and framework in place so you can scale appropriately and build safely over time. One thing we heavily talk about is get your revenue cycle right from day one. It's one of the most overlooked but important lessons is to get your revenue cycle right from day one. We consistently see incredible programs that are of clinical excellence but financially underperforming simply because their billing, coding, and charge capture are not set up correctly from the start. That's where alignment with finance, your clinical team, and integration health becomes critical very early, and not after your go live and not after the first 3 or 4 patients, getting that started before your go live date. Educating clinicians is ongoing work. I think most of us know that, whether it's an ECMO program or any program in your hospital. It's not just a one-time event. It's a continuous process even after go live. You're constantly reinforcing competencies, running sims, onboarding new staff, and evolving with best practices. And that's where your ECMO coordinator really comes into play with that strong clinical background and willingness to continue to build and maintain your infrastructure. Kudos to David. We help structure education across pre-go live, year one, and beyond because sustainability depends on it. Integration can help you guys provide short-term and long-term education programs as your partner. Ryan just alluded to really growing the market, and that's where a lot of your patients are going to come. Think regionally. Don't just think about in your hospital. The second you say, hey, we're not going to think outside your hospital, that'll be the first call you get. You shouldn't think in isolation. There are patients in surrounding hospitals who need your program, in your community that need your program, but those referrals don't happen automatically. They take a lot of work. You must show up, you must build relationships, and establish yourself as a regional resource. The Lake has done an incredible job over the last 2 years being that resource for Baton Rouge and South Louisiana and moving into Mississippi and North Louisiana. Transport and outreach programs become a major growth driver for your hospital's ECMO program. You can go to the next slide. As you look at this list, some of you might be overwhelmed. Most hospitals will find that they have some of these elements, but not all of them. And that's okay. The reality is you don't need every box checked on day one. What matters most is the institutional commitment to patient need. The rest, whether it's staffing, education, infrastructure, that can all be built over time in the right partnership. That's really where integration health comes in, helping you take what you already have and build a sustainable, scalable ECMO program around it. Today, ECMO is still often considered the wild, wild west. You can look at 10 programs and they're all run a little bit differently. So we try not to come in and make you look like the hospital down the street or a hospital in another state. We take the resources you have and build a program that's sustainable for your hospital, for your community. So it's less about are we 100% ready today and more about are we ready to start the pathway to build this program. Next slide. So why partner? At the end of the day, launching an ECMO program isn't your hospital's only priority. I would hate to see Ryan Landry's to-do list every single day. You're managing a lot of competing initiatives at the same time. That is our only job and our only goal day to day. What partnership really does is take something that can be operationally very heavy for your clinical team, for your hospital, and we help carry that load. So you can move faster, reduce risk, and bring expertise to the bedside immediately. Partnership doesn't replace your program. It helps you build it without slowing everything else down. We have really enjoyed our partnership with Our Lady of the Lake over the last several years, and we look forward to continuing that partnership. You can reach out with any questions. I think I've seen a couple questions pop up in the box below. And then you should have all of our contact information to either reach out to the lake or anyone at Integration Health. David and Ryan have been an incredible resource for other hospitals looking to start sharing their 12-year journey and then what the last 2 years have looked like for them. So I know that Ryan and David always raise their hand to help other programs as well.
Well, thank you all. That was terrific, and it has generated quite a few questions. So I'll start with you, Ryan. Just as a follow-up, what would you say to a hospital administrator who is on the fence about starting an ECMO program?
Probably the easiest way to answer that is to call Nicole. But I guess more granular, it's really just get to your numbers, like define the need. So we went through a historical review of our patients, use classic inclusion exclusion criteria and try to find out how many patients we have that were in our center, came through our ED that, may have benefited from this type of program, how many patients we ended up sending out through our CV program. And that kind of gave us a base to pique other interests. The finances get really scary, and for hospital administrators there that are maybe new to how hospital accounting works, it can be challenging, and it seems like the rules always change. So I would take your time going through that, and reach out to experts. There's a number of them all around, probably in your region, that can help kind of make north of some of the static that you may see. Um, every program's a little bit different. Um, I've always been linked to programs through a dyad model. I think having a physician, and maybe that's just the nurse in me, having a physician that fully understands and helps me understand aspects of the clinical pathway that I didn't really know, and trying to march a patient through, as it was one of your family members, through what that pathway would look like. Those are all the types of questions that we did early on, and we did as a group. It allowed us to kind of get feedback from the different departments and provide a different perspective, and I think overall helped us in our comfort of being able to get into a subspecialty like this.
So, as a follow-up, knowing what you know now, is there anything you would have done differently in the implementation process?
I think we were very prepared for our program. I'm not sure if we had any issues that I would have wanted to like hedge off even to this point. Um, just because it was busy and probably wasn't a task that we had with Integration Health, and could have just been my own fault. We could have done a better job of educating all the different services. I mean, I mentioned earlier we had 60 medical specialties on this campus is really getting out there and spending a lot of time with the ED physicians, some of these emergency rooms that are standalone EDs, going out to some of these smaller hospitals and not just talking to their admin team or their med staff team, but actually going to their emergency room and speaking to those folks. So there's probably more we could have done from an outreach, business development, marketing, education standpoint on the front end. And that is an endless task that we're still doing. And I know some very busy programs feel the same way about it. But that we would have been more thoughtful on that front.
And a question from a member, either for you or for David, did and do you have intensivists and closed ICUs prior to starting?
Yeah, so we've have a, I mean, it's been for decades. We've have intensivists 24/7 here supporting our six subspecialty ICUs, and that model's kind of flexed with volume of intensivists over the years. But now we have essentially an intensivist assigned to each unit, and those units range from 12 to 24 beds in size. And then we have somebody overnight, and we have a list of APPs that kind of help augment that support.
And to add to Ryan's comment, I think what's been really helpful for the success of our program is we cohort all of our patients to one unit, and when there's consistency in care for the bedside team, the physicians do rotate at different intervals. But I do feel like, again, for a new, especially a new program, doing less than 30 cases a year, the cohort of the patient has really made a huge impact in our success rate, and for even just for comfortable level for all key stakeholders, for sure.
Yeah, I mean, it's all the simple like program improvement and quality improvement things that everyone's doing already, like daily rounds, inviting everybody from the multidisciplinary team, inviting other doctors that have some interest, and you really start to see who's interested and who wants to learn, and that starts a whole nother conversation on growth and growth of the team, looking at different patients in different areas that may not have been thought of in the past. So we're trying to be as inclusive as possible.
We have another question from a member. How is your existing perfusion staff utilized in this program?
Yeah, so we have been blessed of having a relatively large perfusion team. They conduct daily rounds with our group. They oversight all of our protocols and orders. They're on call for us, as well as the heart surgery program. So from the jump, they have been deeply integrated in discussions and planning.
I would say that that's
Um,
a common question that comes up quite often, and the involvement of perfusion varies by institution. A lot of institutions reach out to us because they are not blessed with sufficient perfusion staff, and perfusion getting pulled out of the OR into the ICU for ECMO is a major drain for them. And so it is, we've set up programs in all different manners, but it's certainly possible to have an ECMO program that's wholly independent of perfusion and doesn't use any of the OR perfusion resources, or can use perfusion for cannulation, or can be more integrated with perfusion both in cannulation and at bedside. And I think that really varies by institution.
Yeah,
so
and
Dr. Me,
our
oh,
team's
sorry, go ahead.
pretty large, so we have folks that wanted to be involved from the beginning, and those that had no no thoughts of doing anything with ECMO. So yeah, we're a little bit unique, but it speaks to the diversity of how they're included in programs across country.
Yeah, the most common call we get is we don't have enough perfusionists, and we need to have ECMO specialists take over ECMO in the ICU.
Ryan, now that you're 2 years into the program, or David, any challenges that you're still trying to overcome, or is this pretty seamless at this point, would you say?
Yeah, I think we have I mean, every day we have a whole another level of comfort with the program. We have quite a few folks that we've kind of trained up, and they are, I mean, not even a year into kind of being on their own with David, kind of looking over their shoulder. So I think that that's still something that we're working through. I'm not sure that that's necessarily a challenge, but just a process. Um, I don't know. The probably being a faith-based organization, I think there's some ethical implications that we probably didn't have good optics on, and it's nothing to like derail our program, but it we are very thoughtful on things that other places may not be. So it's created some discussions with some of our ethics committees, especially as we get to patients with end of life or just complex questions about their next step may not be something that they had in mind. So I would say that's probably the most recent dynamic that we've had to deal with.
Hey, Ryan or David, could you guys speak a little bit to when your program went live? Integration Health was there 100% as coordinators and 100% as bedside staff. And obviously you're transitioning to where you're doing those things full time. And you've got, David who came from us. Kind of where are you in that transition and kind of talk about how that transition has gone?
Yeah, so we were hoping to keep our bedside nurses focused on being bedside nurses. Like we for dialysis, we have a company that comes in and kind of helps us start with dialysis. So it seemed like a very comfortable thing to have a coordinator that could help us with training, education, ongoing, and then have staff flown in as needed to manage the pump. And that's worked really well. And what has it allowed us to do as we've been putting patients on is to get them just comfortable with it, no different than, a percutaneous VAD years ago. And so now with a cohorted group of folks that have applied and have interest, show up all the time, David has been spending a whole lot of time training those people, putting them through didactic wet labs, all the different experiences that one would want, and then having these shadow shifts where they're overseeing ECMO specialist responsibilities. I
Looking back at the very beginning, I'm sorry, Ryan.
Go ahead.
Looking back at the very beginning, it was very helpful to have IH staff here 24/7 because it allowed me to continue building the aspects of the program with Ryan behind the scenes. So I didn't have to worry about being at the bedside as much. I was able to trust the staff that was here. So again, we kind of grown our own team as we've mentioned, but it's I think some of the easiness of now is kind of looking back at that the the opportunity we had to kind of grow those aspects early in the beginning.
Yeah, the
So
quality of specialists that came in, I mean, David was pretty hard on everybody, and
sorry.
rightfully so. But they all were extremely good at communicating with our team members. We did a decent job of like onboarding them as they showed up for a shift. They knew the specialist components, like so that part wasn't a problem. We have a few little things we may do differently, easily to review. So it just allowed us to kind of get back into our normal work and do other things to help bolster our program and take care of patients.
I appreciate
Yeah.
the shout out to the specialists. I'll say, we serve over 100 facilities across the United States and Canada, and every day we have about 25 ECMO specialists on call with a bag pack ready to go to a hospital when they put somebody on. And those specialists sit on average 11 and a half shifts of ECMO a month. So, they have very deep and ongoing ECMO experience, and they see all the pump types and all the different setups. And so it brings a lot of expertise to a program.
It's a special thing that I just knew from years of looking at staffing agencies for different disciplines, being able to have the variety of folks that have come to us over the past 2 years. I'm not sure if we had any issues from a personality standpoint, and definitely not clinically. So I think that's a real pride point for y'all and for all the teams that have come through here.
And they've
Yeah,
all had really good pride about working for IH and coming here and just being just again that wealth of knowledge for all of our staff. And they've all really came in very respectfully and understanding this is our program. They want to help as much as they can without overstepping that boundary. So kudos to the team from IH and all the travelers especially. Really really appreciative.
yeah, David and Ryan. It's it sounds like you were very fortunate to have a company like Integration Health walking you through every step of the way. But Dr. Mehall, if a program is trying to stand up a program like an ECMO program like this independently, are there some common mistakes that you see that these programs make?
I would say it's more common challenges than mistakes. And I think the biggest ones are when people try and do it organically, they just don't ever get to that critical volume of patients and that critical mass of institutional experience. And so we like to think of it as escaping Earth's gravitational pull and getting into a steady state orbit. It really takes, 20 plus patients a year to start to build institutional experience, because then you have enough people that are sitting bedside frequently enough that they build expertise and then they can educate the next generation of those folks. As Ryan alluded to earlier, I mean, nationwide, it's about 25% of an ICU staff turns over all the time. And so there's a little bit of a hamster wheel problem there. And if those folks are not sitting bedside, taking care of ECMO patients on a regular basis, then those skills are decaying and it's really challenging to keep them up. And it's also challenging to get them comfortable when if you're not comfortable and the doctors are talking about putting a patient on ECMO, then there's a lot of trepidation and that may impede the decision to put the patient on ECMO. And so I think that's the biggest challenge is going from 0 to 60 miles an hour. And that's what we can do in integration health is help people get over that, get to a critical volume of patients so it becomes self-sustaining for the institution.
We have another question from a member that I think is probably pretty important for the audience, and that is, what would you say to someone who says, we can't sustain an ECMO program here if we aren't a transplant center?
I would say we get that question a lot. It's a great question. So thanks for sending it in. And the answer is very few patients actually go on to definitive organ transplant. The overwhelming number of patients do recover. Obviously, some don't make it, but going on to definitive transplant is a minority. And I would say that when that happens, we're happy to help you transport that patient to a center if they need a heart or they need something else, or if they just need destination VAD therapy or something like that. And I think the paradigm of ECMO really as a bridge therapy to buy time. If you look at the ECL usage or other things, in those instances, you're supporting the patient, keeping the brain oxygenated while you find a treatable problem. Maybe they did a LAD stent or a left main or a pulmonary embolectomy or something like that. And, you can stabilize that patient, keep their brain alive, keep their organs alive while you find a fixable problem. And I think that and then, really resting the lungs, eliminating barotrauma, things like that. Those are the majority of ECMO cases. Bridging somebody to transplant is a small minority of cases.
Ryan,
So,
is this ever a
go ahead.
hesitancy for the Lakes program not having heart transplant or lung transplant or LVADs at the time?
No, it wasn't. As we get smarter and a little bit more sophisticated, that's kind of on the outlook. But no, our problem was patients that needed something pretty urgent and emergent. And we're worried about not being able to get those patients out. And hearing the same stories in some of our smaller hospitals around our region. So yeah, have we had to take patients on ECMO and send them to other programs? Of course. And that's part of the plan. But we've shown that there's a sizable group of patients that need the rest. We're able to provide that and they recover. So
Yeah, I think one of
We,
your most famous patients was a postpartum patient, those are great saves. And I think the other thing I was going to comment about is the halo effect it has on cardiac surgery, where, I did cardiac surgery for a long time, and there are a lot of patients where you say, I could probably do this operation here, but there's a small chance the patient would need ECMO, so I'm going to send the case out just in case. And it always hurt as a surgeon to send those patients away when you knew 90% likelihood you wouldn't need the ECMO. And so there's usually a big halo effect around cardiac surgery and the ability to keep those patients if they were to need ECMO post cardiotomy.
I think just this calendar year we've had, 10 or 11 standbys for CT surgery, and those are patients that probably would have been sent out years past. Granted, we only have put one of those patients on, but it's still a huge um, level of comfort for the surgeon, especially in that immediate post-op time period.
Dr. Mehall, a question is, if the financial team is skeptical if the administration team is skeptical about the financials, how do you help to walk through that and come to an agreeable solution?
Data. Nothing dispels skepticism like data. And so it's very easy. We can go through, we can model with your hospital, your DRG reimbursement, your payer mix, what your charges would be, et cetera, and just show them the actual finances of a patient with Medicare, a patient with Medicaid, a patient with XYZ commercial payer, and show them what their reimbursement would be when that is coded, charged, and billed correctly. And so that we do that all the time, and we model that out, and we certainly do it for all the programs that we're going to start.
I would add
Okay.
our experience with IH is the build performance as administrator for a number of different programs. The level of detail for this type of program and the number of pages and getting as granular as to the disposables that are being used was helpful for us to really show that there was nothing missing and no things hidden whenever we were getting our conversations going with our finance team.
I agree.
Okay.
From
I'm
a
sorry. Go ahead, David.
sorry, coming from a coordinator perspective, it was really uh, comfortable to come here and see what IH had laid out the groundwork, especially for my side of the bed, and seeing how they follow a lot of ELSO guidelines, which is a huge thing in the ECMO community, as we know, and a lot of things are kind of planted in Brian's head and administration's head, how we probably should run the program. So again, that was very helpful for at least for me.
Okay. Before Dr. Mehall, I'd like to ask you if you have any final comments. Before we get to that, though, I do want to remind everybody that in the chat, there is a link to download today's presentation. We've also recorded today's presentation, and we'll be pushing that out to the membership so you can view this or share this with your colleagues at another time. But any closing comments, Dr. Mehall?
I would like to thank everybody for taking the time to listen. I know you're all busy and you have other things that demand your attention. And as Chris mentioned, this will be through MedAxiom, and also all these webinars and all the financial presentations I alluded to are also available on our website.
So thanks to all of our members that attended today. Thank you for Integration Health for sponsoring today's presentation. And with that, we'll bring this webinar to a close. Have a great afternoon, everyone.
Yeah.